for our beers and criteria here, we noticed that our patient is on quite a lot of medication, so polypharmacy is definitely one of our concerns here. We saw several medications were on the Beers criteria, and there was also a lot of interactions that can be seen between these medications as well. She's on some of these that are definitely drying, as well as some that can work against or are antagonists against other medications. So we would kind of just go through, do our own med reconciliation, because we want to know how these things are all acting together and why this patient is having the issues with the falling and the UTIs. So we want to look at the medications, her past medical history, and see really what's going on there. It's important to know backgrounds, and it's important to know what kind of drugs she's on, so we're familiar with how these all work together.
After checking out the Beers list and comparing that to the list of medications that our patient is currently taking, we found that losartan was one of the medications that this patient was taking and was on the Beers list. It also had a few other drug interactions and some concerns with polypharmacy, so that's one drug we would definitely take a look at with this patient. Quetiapine for her hypertension, that drug also was on the Beers list, and we would look at that. Some of the options we have when we have...
The quetiapine is actually Seroquel, which is going to be one of our antipsychotics, because she does have a mental history here, but that can work against some of the blood pressure medications that she's on, and she's on several, causing an increase in hypertension as well.
So we would really look at the benefits that that medication is providing for our patient and make sure that that still outweighs any of the risks that the polypharmacy or the Beers criteria have with that medication. A decrease in dosage is also an option with aging individuals. Oftentimes a lesser amount of a drug is necessary, and so we would look at dosing.
And isn't one of the hypertensive or blood pressure medications that she's on the Beers list also, isn't metoprolol on there? Or am I wrong?
Well, I didn't see metoprolol on the Beers list, but she is on the losartan, metoprolol, and amlodipine, and I think that was...
And she's on a sliding scale insulin, which is contraindicated in geriatric patients of her age because it, can cause hypoglycemia without controlling the hyperglycememia.
Well, and there was some confusion on the insulin aspart. It says 10 units with meals. Well, does that mean every time she eats? What does that specifically mean? That wasn't really clear to me. So I would want to know more about that as well versus the other medication, or her insulin, it was 30 units every night. That's clear.
One of the meds did cause something with the kidneys, which could be the reason for her reoccurring UTIs. I just can't remember what it is.
Amlodipine, I believe.
Was it that? Okay.
It might be. And so just looking at a lower dosage for that might be one way we could help this patient.
Yep. And any of these that have drying effects, if that's going to cause urinary retention, definitely plays into UTIs. And plus, another reason for UTIs is how well is she actually cleaning herself after she uses the restroom? Does she have help for that, or does she not? We don't really know.
She is in an assisted living facility. She has a nurse that comes in once a week, but from what I understand, she only deals with kind of like making sure, like setting out the meds, making sure that she's taking them, stuff like that. It doesn't say anything about daily cares, right?
So
right.
we don't know how she's being cared for. If maybe that's the reason
she can do
for
it
one of the
herself.
UTIs. If she's able to maybe not take care of her toileting needs very well, or if the hygiene isn't really there either. Like, how often is she getting a shower or bath? How often are they doing peri-care? We don't know.
And I think that's something that would help with her meds, would also be not just viewing her medication via her past medical history, but like having them bring in everything she's taking.
Absolutely.
Like all of the bottles, making sure that the right meds are in the right bottles. I mean, this woman is left alone a lot and, is having you know, mental alertness problems,
Yeah.
dementia, you know,
So
mood disorder. Who knows what
if she
she's
is
doing?
taking these as prescribed, or
Flushing down the toilet.
yeah, or just not taking them, whatever she's doing, or if she decides one day, well, I'm not going to take this medication. So, you know, just the compliance there, really making sure that she's getting the care that she needs to make sure what medications are appropriate for her, what medications maybe are not, what are causing interactions between and causing, you know, some of these anticholinergic effects that she may be experiencing with the falls or urinary retention, anything that way too.
Yeah.
And currently it had indicated on the MAR that this patient was in the wheelchair and she was responding. She was alert ×3, alert and oriented ×3. But being that she is in a wheelchair, that does raise some question.
Mhm.
And the daughter had mentioned that her past physician had wanted to place this patient in a home.
Yeah, nursing home.
So he or she could have seen that this patient may require some additional assistance.
Absolutely.
Other than that once weekly visit from the nurse.
Yep.
And from the appearance of it, it looks like she, I mean, that polypharmacy is a thing for this patient. Like,
Right.
yeah, her med list definitely needs to be improved.
Yep, so definitely med reconciliation, as well as getting a social worker involved to see if there's any
Yeah.
gaps in care that way too.
Yep. Are we done?
Yep.
Okay. And I'm here too.